The educational messages that were promoted, and these are the messages I learned when I was in medical school, and many of these messages are still taught today, maybe slightly tweaked, but the medical community was being told by its professional societies, by pain specialists, by medical boards, by the Joint Commission, that addiction to opioids was very rare in pain patients. And the statistic that would be used was that much less than 1% of patients would develop addiction. The medical community was told that we were needlessly allowing our patients to suffer because of opiophobia. We were taught that opioids are safe and effective for chronic pain. At an educational event, a case vignette would a case example would be brought before the audience, sometimes a video of a patient telling you that they got their life back because they were put on long-term opioids, and that before they were put on OxyContin, for example, they were unable to work, and now they're on OxyContin, they have their life back, they can go back to work, they can take care of their family, they can buy their child a bicycle. And the message was that opioids were safe and effective for chronic pain, and that this was the compassionate way to improve the quality of life in your patients suffering from chronic pain. What we know very clearly today, and what we probably should have known even then, is that opioids are probably not safe or effective for most patients with chronic pain. And in fact, when you look at individual workers, particularly with data that's coming from the workers' comp industry, if an injured worker has their chronic pain treated with opioids, that worker is far less likely to ever go back to work again than if they were to have their chronic pain treated with any other possible intervention. And lastly, another very common message was that while addiction was extremely rare, physical dependence was something we should expect, but physical dependence is not a problem because opioids can be easily discontinued. And the example that would be used, and that's still used today, is that physical dependence on opioids would be compared to physical dependence that we see with other medicines. For example, the comparison might be made to a medicine for blood pressure, where if you stop the blood pressure medicine abruptly, one's blood pressure might be elevated. Or the comparison might be made to an antidepressant, which if stopped abruptly might give a patient a couple of days of feeling uncomfortable. Or even a comparison would be made to caffeine, where if a regular coffee drinker doesn't have coffee, they get a headache. And you were taught in these educational programs that physical dependence is like with all of these other examples, is nothing to worry about. It just means you have to taper your patient off of opioids. Again, what we know today and what we knew then, very well then, because we had data going back to the 1950s to indicate that coming off of opioids, even for patients that are not clearly addicted, is difficult. That there are acute symptoms that are extremely unpleasant, which is why people will check themselves into hospitals for detox. It's why we see a proliferation of these ultra-rapid detox programs where people will undergo the risk of general anesthesia just to get over the acute withdrawal symptoms. But what we've also known since the 1950s is that there are prolonged withdrawal symptoms. So even after a patient is over the acute symptoms, there are often months of insomnia, irritability, depression, leg kicks in the middle of the night. And even for people who may not have appeared to have been addicted prior to discontinuing opioids, they'll often experience cravings. So discontinuing opioids is certainly not easy. Where did this figure come from that much less than 1% of patients will become addicted? Well, if you were reading a journal article or a chapter in a textbook or listening to a lecture, you might have this statement presented, that only 4 cases of addiction were found among 11,800 patients treated with opioids. And that's where that figure came from, that much less than 1% would become addicted. Now, if you were reading a medical journal and you came across the statement, much less than 1% will become addicted, or only 4 cases of addiction among 12,000 patients treated with opioids, And if it struck you as strange, if you weren't quite buying it because you understood that we're talking about drugs that include in their class heroin and that are highly addictive, and you thought, oh, does that really make sense? Only 4 people would become addicted. So you might turn to the back of the chapter or to the back of the journal article, and what you'd see as the reference would be this listing here: Porter and Jick, Addiction Rare in Patients Treated with Narcotics, New England Journal of Medicine, 1980. And you have to remember now it's in the late 90s and in the 2000s that suddenly everyone is citing this old article, and the press is even talking about this as having been a landmark study that proved that pain patients didn't get addicted to opioids. Now you might look at this if you were skeptical and you might say, well, New England Journal of Medicine, it doesn't get much better than that. That's one of the top medical journals in the country. So you might say, well, that looks pretty good, and you might just flip the page and keep going. But if you still weren't buying it, and you said, I really want to see what they did in this study because I can't see how possibly they could have only found 4 cases of addiction out of 12,000 patients. So if you went to your medical library to pull out Porter and Jick, which everybody was citing, what you'd find out when you pulled out the 1980 volume and turned to this page, you'd find out that what everybody was citing as proof that patients didn't become addicted was a 1-paragraph letter to the editor of the New England Journal of Medicine, in which chart reviews of 11,882 patients were described, where they had only found 4 cases where a nurse or a doctor jotted down in the chart after a hospitalized patient had been given morphine or Demerol, that the patient appeared to be drug seeking. This, of course, would tell you nothing about the risk of addiction when patients would be treated long-term with opioid analgesics, but this was the evidence that we were given that was used to encourage long-term use of opioids for chronic non-cancer pain. In the past couple of years, there have been multiple editorials published in top medical journals arguing that the medical community made a disastrous mistake when we bought into this notion that treating chronic non-cancer pain with opioids was the compassionate way to treat pain patients. As you see here, that one of the best of the bunch here was written by folks in Canada, Dr. Dahlan, Dr. Gerlink, and published in the British Medical Journal. All of these editorials have had a similar theme, which is that we're harming far more patients than we're helping when we put them on long-term opioid therapy for their chronic pain. And just last year, the New York Times spoke with Jane Ballantyne, who's also a member of Physicians for Responsible Opioid Prescribing. Jane is a well-known pain specialist. She's the author of one of the leading textbooks that's used in pain medicine. And this was her quote for the New York Times. I think that after 20 years of a failed experiment, that there are not many people supporting this except for the diehards and the pharmaceutical industry. And I think that I certainly agree with Jane, which is why I'm using this quote, but I would probably add to this that there are also many in the medical community, really a generation of doctors who have been very badly misinformed, who've been encouraged by their medical boards, their professional societies, by their hospital administrators to be prescribing opioids aggressively, and may not have yet figured out that they're harming more of their patients than they're helping when they do this. So what do the diehards and the pharmaceutical industry say? Certainly if you're making a product where, remember that green line that the CDC showed us with opioid consumption going up and dragging up the red line, overdose deaths and I think it was a blue line for addiction. Well, if you're the maker of a product where increasing use of your product or increasing profits are associated with increasing harms to society, you're certainly not going to be happy about that. But you're probably not going to want to see that green line go down. And what you'll probably do, and which is what the industry and the pain organizations who are taking funding from industry argue, is that there's a way that we can have our cake and eat it too. That there's a way that that green line can keep going up. But if we teach doctors what they call the new paradigm, that's how we can have our cake and eat it too. That's the way we can see that pain patients will have access to opioids while reducing the harms associated with increased consumption of opioids. And what they teach is that, or what they argue is we should be telling our primary care doctors, and what they are teaching our primary care doctors, is that they should use patient selection tools that help you stratify a patient on the basis of their risk of becoming addicted, and then the patients that are higher risk, that you should monitor them more closely. And that if you do all of these things, that it all turns out safe and effective. So for example, what they teach in their courses is that if a patient comes to a doctor's office and complains of pain, that you give her an instrument, a survey to fill out, a questionnaire to fill out, and the patient fills it out, and you look at the answers and you see whether or not that person might be high risk for addiction. Now, we certainly know that even patients without any risk factors for addiction can easily become addicted when you put them on long-term opioids, because opioids are highly addictive. But certainly there are people who may be at greater risk. What they argue is that the people who turn out to be higher risk when you give them a patient selection questionnaire, not that you shouldn't give them opioids, but that you should stratify them to the higher risk group, which would mean that you see them more frequently, you monitor them more closely. It means that you might check a prescription drug database to see that the person hasn't started doctor shopping. And that if you monitor the patient closely and you do all of these things, well, if the patient starts to have a problem, you take the patient off of opioids, no harm done. But actually it doesn't work out that way, because even with the closest of monitoring, the point at which the prescriber is going to recognize that there's a problem, if they ever recognize there's a problem, and there are strong motivations for the patient to hide the fact that there's a problem once they're addicted and their doctor becomes their supplier. But the point at which a doc is capable, even with the closest of monitoring, of figuring out that there's any problem, the damage is already done. Now that doctor may decide to stop prescribing, but the patient is left with the disease of opioid addiction, and it's a disease that may kill the patient, and the patient isn't going to stop using opioids or suddenly get better simply because that doctor decides not to prescribe anymore.